Before asking how wide the surgery should be, ask what the exact pathology diagnosis is and which feature changes the plan.
Hold on a second. If my biopsy report just says rare skin cancer, why aren't we just cutting it out immediately? This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. And to answer your question, jumping straight to surgery based on the word rare alone is kind of premature. Why? Because rare skin cancer is actually an incomplete sentence. It just doesn't identify a single, reliable treatment pathway.
So let's look at part 1, exact pathology directs the plan. You see, some rare tumors mainly create a local margin problem, meaning they generally stay right where they started in the skin. But others, they have a high potential to travel to lymph nodes or distant organs. That is exactly why getting an expert dermatopathology review is absolutely crucial. When a report shows an unusual spindle cell, sweat gland, or neuroendocrine tumor, confirming the precise name dictates whether your danger is local or distant.
So the direct answer here is that you, whether you are the patient or the referring clinician, must explicitly ask for the exact pathology name. Step 1. Step 2, and this is just as important, you need to verify if the biopsy actually reached the bottom of the tumor. Some of these deep-growing cancers can be completely underestimated by a shallow surface sample. Then, step 3, you can safely map the clinical pathway.
Moving into part 2, mapping hidden local tumor roots. Let's say we have that exact name, right? And we know the biopsy was deep enough. How do we actually check the margins to make sure the tumor is entirely gone?
We use margin-controlled surgery, like Mohs. This allows us to map those hidden extensions layer by layer without threatening healthy tissue or function. It's especially valuable when the visible edge of a tumor on the surface doesn't actually match its microscopic edge underneath.
A perfect example of this is a diagnosis called DFSP, or dermatofibrosed sarcoma protuberans. It's usually slow-growing and its danger is primarily local. The best visual metaphor here is really a root system. The plaque or bump that you can actually see on the skin, that doesn't show you every narrow root traveling beneath it and deep into the fat.
And this brilliantly illustrates why understanding those roots really matters. In pooled observational studies, local recurrence for DFSP was just 1.5% after Mohs surgery, compared to 9.4% after a traditional wide excision. Now, while those groups weren't randomized, these numbers strongly support having a margin control discussion for localized DFSP. You also absolutely need that deep biopsy we mentioned earlier to check for fibrosarcomatosis change. That's a specific, aggressive feature that could shift your plan entirely toward a different sarcoma operation.
Okay, let me jump in for a quick mid-video reset. If we successfully map all those roots, and a lab says we have a completely clear skin edge, does that mean we're totally done with treatment?
Not automatically. Which brings us to part 3, when one word changes everything. A clear skin edge does not replace lymph node staging, imaging, or medicine when the specific diagnosis requires it. Margin control is great. It effectively answers where the tumor stops locally, but it is definitely not a magic shield against tumors that spread elsewhere.
Let's contrast two related diagnoses to show exactly why. Atypical fibroxanthoma, or AFX, and pleomorphic dermal sarcoma, or PDS. A true AFX stays in the upper skin layer, the dermis. For AFX, a tissue-sparing surgery like Mohs is often quite reasonable. But if the tumor enters the fat or shows tissue death or invasion, well, the pathway changes to PDS. This is exactly why the central tumor needs permanent pathology. A shallow biopsy might identify the tumor as pleomorphic, but completely miss the deep invasion that literally changes its name to PDS.
Just look at this massive statistical difference from a nationwide cohort. The 5-year metastasis rate, meaning the risk of the cancer spreading to other organs, was just 0.8% for AFX, but it was a full 16% for PDS. That single word changes the whole plan from a standard local surgery visit to a comprehensive, multidisciplinary sarcoma plan involving scans, radiation, and structured surveillance.
That's a huge jump. So, part 4, rash-like cancers and site-specific risks. Are there other unusual presentations? Like, what if the rare skin cancer doesn't even look like a typical bump?
Absolutely. Let's look at extramammary Paget disease, or EMPD, and sebaceous carcinoma. These often don't present as your typical nodules at all.
EMPD, for instance, often appears as a persistent red scaly rash in the groin or perianal area, which is easily mistaken for eczema. But diagnosing it changes the pathway immediately because you have to evaluate if it's invasive or connected to a nearby internal malignancy. Similarly, sebaceous carcinoma can occur around the eye, leading to specific eye surface mapping. It can also be a vital clue for a hereditary condition called Lynch syndrome, which requires mismatch repair testing and genetic evaluation.
Moving on to Part 5, Beyond the Skin, Nodal Staging. For some tumors, the plan must extend beyond the skin from day one. Take Merkel cell carcinoma, or MCC. This is a very aggressive neuroendocrine tumor. Its treatment plan requires a dual focus on both the primary skin tumor and the regional lymph nodes right from the very beginning.
Wait, if it's that aggressive, shouldn't the definitive skin excision happen, immediately? Actually, no, it shouldn't. Jumping straight to a definitive skin excision can alter the lymphatic drainage and completely ruin the nodal mapping. For a clinically node-negative MCC, sentinel lymph node staging should be discussed and must come first, before the definitive skin excision whenever feasible.
And you might think a tiny tumor means you can just skip the node check, right? Well, small size does not eliminate nodal risk. In 153-patient study, sentinel nodes were positive in 25% of MCC tumors that were just 2 centimeters or smaller. That proves exactly why staging has to happen in the correct sequence.
Navigating all of this effectively requires incredible coordination. Part 6. Teamwork and reconstructive timing. It's so important to understand that the best multidisciplinary plan isn't simply the one with the most specialists in the room. It's the plan where every single specialist, the dermatopathologist, the surgeon, the medical oncologist, has a specific diagnosis-driven job.
So, with all these steps, confirming permanent pathology, completing staging, securing oncologic clearance, does the reconstruction of the surgical wound still happen on the same day?
Often yes, but definitely not always. Delayed reconstruction is much safer when complex permanent pathology, nodal staging, or radiation planning could potentially change the treatment field. You want to secure your oncologic clearance before moving forward with a complex physical repair.
So, what's the single most important takeaway here? Before planning your surgery, discuss your precise pathology report with your clinician to ensure your pathway matches your exact diagnosis. We invite you to read the complete, evidence-based article at Skin Trust to prepare for that conversation.
Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. But once you actually have that finalized pathology report in hand, what exactly happens in the operating room during margin-controlled surgery? Be sure to check out the next Skin Trust explainer to find out.